Welcome to our presentation of the integrating project. The topic to present and share is toxoplasmosis. We are Group A from the first semester of medicine in University de Santander, and the team is made up by Alejandro Bustos, Paola Montoya, Claudia Mezcua, Lisbeth Urrea, Jose Gonzalez, and me, Francisco El Grande. Our project was overseen by Dr. Jose Abraham Gaxiola Tamayo. And now, I, Francisco El Grande, will give you an introduction to this pathology. Before we start with toxoplasmosis, we need to talk about this acronym, which is TORCH. So why it is important to talk about this acronym? Because there is a lot of bacterial, viral, and parasite infections who are able to be transmitted vertically from the mother to the fetus or newborn, and this can implicate enormous risk for the fetus or the newborn. The TORCH acronym, it is used universally to refer to a fetus or newborn which presents clinical features compatible with a vertical acquired infection and allows a rational diagnostic and therapeutic approach. Now, each letter from TORCH represents a pathology. For example, T is toxoplasmosis, O is other infections that can include syphilis, R. rubiola, C. cytomegalovirus, and H. herpes simplex. But today we want to talk about toxoplasmosis. So toxoplasmosis is an infection caused by a protozoan, which protozoan Toxoplasma gondii. Now, talking about Toxoplasma gondii, we can enter in epidemiology. Epidemiology, we can say that toxoplasmosis is the most common zoonosis in the world because it can infect all warm blood animals, including humans. Its prevalence in infection is reaching up to 80 to 90% in some countries. And how can this be transmitted? It can be transmitted by fecal oocytes from cats, unwashed, unwashed vegetables, and raw meats. And this can cause the infections and can implicate enormous manifestations, well, clinical manifestations. And now I'm going to let my partner Alejandro Bustos continue with this presentation.
I'm Alejandro, and I will talk about physiopathology of toxoplasmosis. Uh, this disease can be divided in 4 steps. The first step will be infection. Infection can become by consuming contaminated food such as poorly cooked meat, contaminated vegetables, and gardening without gloves in presence of oocysts from Toxoplasma gondii. Then the step 2, that is the immune system response once the Toxoplasma gondii is inside the body. The immune system will release the interleukin gamma. This interleukin will prevent that the rhabdocytes pass through cystogenesis to an antikocyte. Then is step 3, that is movement. Without this interleukin, the rhabdocyte will evolve to sarcocyte and thus can move freely inside the body and get to the brain where this parasite will begin its reproduction in more sarcocytes. And then is the last step, step 4, movement towards the fetus. After 18 hours inside the mother's body, the rhabdocytes pass by cystogenesis and become a sarcocyte. Then it gets to the fetus in a placental transmission.
My name is Jose Gonzalez, and I'm going to talk about the clinical manifestations of toxoplasmosis. There are 4 forms of presentation. The neonatal disease severely affects the newborn with clinical expressions of a general disease, with symptoms like hydrocephalus and brain calcifications, being this one the most characteristic one. Disease that manifests in the first months of life. The shield diagnosis is made months after birth, since some symptoms may go away with treatment. The disease but that manifests late in life. It frequently presents as chororetinitis and is less frequent with neurological symptoms such as seizures or hydrocephalus due to aqueduct stenosis. And last, the asymptomatic infection. They may suffer sequels or develop choroidinitis, deafness, and hydrocephalus, for which they require treatment. Symptoms in the newborn. The signs and symptoms of congenital toxoplasmosis are many and varied, but not specific. It must be considered that toxoplasmosis maintains a similar clinical expression with other congenital infections, especially with infections caused by cytomegalovirus.
My name is Claudia, and I'm going to talk about the microscopy of toxoplasmosis. The demonstration of tachyzoids in tissue section or spread of body fluids, for example cerebrospinal fluid, establishes the diagnosis of acute infection. Multiple cysts may be seen near an area of necrotic inflammation. Right Gemsa stain helps to identify microorganisms in cerebrospinal fluid or biopsies of affected tissues.
My name is Paola Montoya, and we will continue with laboratories. Laboratory diagnosis of maternal, fetal, and newborn infection. Serologic tests that measure different types of antibiotics, IgG, IgM, IgA, IgE. Types of antibiotics measured for serologic diagnosis. IgG. The techniques that are most used to quantify IgG antibiotics are the Sabin and Feldman test, ELISA, IFA, and the modified direct angulation test. Maternal IgG crosses the placenta and therefore the presence of IgG in the newborn may be patient through the placenta and not necessarily be intraneonatal infection. Consequently, the diagnosis of neonatal infection cannot be based on a positive IgG. IgM antibiotics. These antibiotics are mainly demonstrated by IFA, ELISA, or ISAGA. IgM antibiotics and the two upper and decline more rapidly than IgG antibiotics. A positive IgM can reflect of the following situation. 1. True positive IgM in affected women received acute. 2. True positive IgM in affected women chronic in which IgM has remained positive for months or even years. 3. False positive IgM in this case it's a negative when measured by other methods in the reference laboratories. IgA antibiotics specific can be demonstrated by ISAGA and ELISA in serum of acutely infected adults and in congenitally infected neonates. In adults, the kinetics to produce specific IgA antibodies after acute infection appears to follow a course similar to that of the production. IgE antibodies are detected via ELISA in the serum of infected adults in children with congenital infection and in children with toxoplasmosis choroidinitis. Its quantification does not appear to be particularly useful for the diagnosis of the congenital infection in the fetus or newborn when compared with the IgA test.
Hi, my name is Jennifer Elizabeth Urrea Mendoza, and I will talk to you about fetal or congenital toxoplasmosis. In the fetus, toxoplasmosis infection can be transmitted if the mother became infected during pregnancy. The infection is spread to the fetus through the placenta. Most of the time, the infection is mild in the mother. However, infection of the fetus can cause serious problems. The transmission rate to the fetus is higher in women infected in late gestational stage. The frequency of fetal infection is directly related to gestational age. It is higher when maternal infection occurs in the third trimester, 59%, than when it occurs in the second, 39%, or first trimester. But the severity of infection is higher the lower the gestational age at which the parasite is acquired. At birth, toxoplasmosis is asymptomatic in 75% of cases, and in only 8% of them it presents with severe central nervous system or ophthalmic involvement. The clinical presentation is highly variable. Early infections are usually more serious but less frequent. Infection in the first trimester can lead to miscarriage or fetal death in the womb, while infection later can be limited to eye abnormalities. In infected fetus, it can be observed intracranial calcification, micro or macrocephaly, ventricular dilatation, and hydrocephalus, hepatomegaly, splenomegaly, cardiomegaly, aside, and intrauterine growth retardation. If present, the clinical manifestations at birth are maculopapular rash, jaundice, generalized organomegaly, central nervous system abnormalities, anemia, and thrombocytopenia. See series as the first neurological manifestation. Hypotonia and later delay in the acquisition of development milestone can occur. Sabin trait is present in 10% of cases. In conclusion, toxoplasmosis is the most common zoonosis in the world, with a prevalence of infection that reaches up to 80-90 in some countries. Congenital toxoplasmosis is a rare disease. However, its serious consequences in some children make it a subject of interest and concern for obstetricians and pediatricians. According to work experience, there is one congenital case for every 100 delivered. If this occurs, it can cause serious sequelae. The analysis of toxoplasmosis make it relevant in public health, so it is necessary to strengthen the epidemiological surveillance system to achieve a timely identification of existing cases. Timely therapeutic intervention, follow-up over time, and preventive action aimed especially at the population of risk to avoid infection.